So we'd like to capture that around the world and make sure that we really share a very clear level of evidence to policymakers as the work progresses. But importantly, and again, Lewis, you mentioned this very clearly, we know what's happening now, but what are the downstream effects of that? And can we model that over time such that we can plan for recovery, but also look at mitigation and planning for the future? So there's a big modelling group that's now been established, looking at a number of areas, particularly on prevention and screening, early detection, as well as treatment and palliative care. And the idea really there is to be in this area for a number of years, so we can really start to take the data that's coming out over time to really inform the longer term planning and the population-based sort of level of decision-making that's required. There is also a focus on healthcare workers, and it's great to hear that you were able to manage well in your setting in New York, Lewis, but the challenges, of course, around the world is quite different. So this is a survey to look at the immediate impacts, what fears oncology health workers have, and how best to manage that moving forward. And I think across all of this work, we're recognising a number of cross-cutting things, the need for more research, the need to draw out new practices and take them forward. We've only touched a bit on economic impact analyses, but of course, as soon as we move out of higher income settings, that's even more acute. And we have big concerns in a number of cancer centres in lower income settings that COVID-19 will divert funds from cancer centres to the extent that they may not ever be able to re-establish the level of cancer services that they now have. And a big issue for us is to look at inequalities. We know there are already inequalities in access and outcomes in cancer care, and we truly expect COVID-19 only to exacerbate those, so we do want to shine a light on those areas. Next slide, please, Sam. So this is just a few slides just to show you what is currently available and how you can get involved. We have established a cancer intelligence hub where we're really trying to pull all the literature together. We're divided really into 4 main areas: risk factors for cancer patients, management during the pandemic, and the impact of lockdown and self-isolation measures, but also looking to pull together any groups that are working on COVID-19, have patient registries or other research initiatives that we can bring together to really inform the process moving forward. And one of the new needs now we're starting to get literature coming through, is to have some expert digests. And I think this will be a great opportunity for this group to provide that expert digest to radiotherapy, because there's over 1,000 papers out there already on experience across the world, and that's very difficult for anyone to keep up to speed with whatever's going on, whether that information is peer reviewed, whether that recommendation is evidence-based. So having some good digests as we get more and more information coming through is a focus area for the Intelligence Hub. Next slide, please, Sam. I mentioned the modelling group, and if anyone would like to get involved in that, this is the emerging website. I'm not sure if it's actually live yet, but if you would like to get involved in the modelling, this is the dedicated email address, covidandcancer@newsouthwalescancercentre.org.au. And there are a number of streams of work. I'm not sure if I included a second slide on this one, Sam. Oh, yes, I did. So again, 3 working group areas at a higher level, looking at prevention, particularly vaccination, screening, particularly those high impact cancers, breast, cervical, colorectal, but potentially also lung cancer and prostate cancer, and also looking at cancer treatment. And in that, we also include supportive and palliative care. There'll be 2 reference groups, one from the infectious disease modelling. And this is really important because we want to make sure the infectious disease modelers do include non-COVID based health impacts in their work moving forward. And of course, we need their expertise in our work as we take the modelling forward. And we're also establishing a clinical expert reference group And that's where we'd love to have any connection with this group to make sure that the emerging learnings from the radiotherapy space can be built in, and that we can potentially engage this group when we're looking at assumptions for the modelling going forward. So it's great that this is being run and managed out of the University of Sydney. We've got a dedicated secretariat there, and as more and more information emerges, I'm happy to share that with this group. Next slide, please. The work on healthcare workers has already got ethics approval in the UK and Canada. A number of countries are signing up to that. So if you're interested in getting involved in that, it's really looking at the psychosocial impacts on healthcare workers, both within the work environment and at home. So if you're interested in getting involved, Christopher Booth, who works out of Kingston in Canada, is more than happy to share the materials so you can take it forward and also give advice if needed. Next slide, please. So I think we've covered this, the areas where we expect some impact in the longer term, and these are the areas that we want to focus on, both in the modelling but also in our policy work. I think that's our last slide there. I can stop and take a couple of questions here, if needed.
Any questions for Julie there? That's really interesting. We need to, again, after the positive story we've heard for radiotherapy, it's really very important we come to the table on this, isn't it? Because there is a lot of issue. No, absolutely right.
I agree. I'm sorry that we rushed through it, but yeah, I'm happy to follow up with more specific questions or discussions at a later point.
Yes, good idea. Yeah.
The other area that Pat asked me to share with you, Sam, if you could switch to the other deck, is to just give those of you that are less engaged in the global space to talk about how radiotherapy has started to have more of a share of voice at the global health and development stage level, and give you just a picture of where we can actually use the positive story that we've heard about from Lewis this morning on radiotherapy to try and maybe lift again the focus on radiotherapy and cancer management with both bilateral donors but also UN agencies and ideally also funders. So next slide please, Sam. This is a slide I use to show the evolution of our advocacy for cancer control actually over the last number of years. We joined forces with others in the non-communicable disease area because we really just did not get any attention on cancer at the World Health Organization or with development organizations and donors. So back in 2009, we started a journey to really achieve two goals. One was to have a high-level meeting of the UN on non-communicable disease. And the second was to make sure that whatever replaced the Millennium Development Goals, which were due to expire in 2015, we wanted to make sure non-communicable diseases were embedded in there. So this alliance really started with just those very simple targets. We were laughed at by many, but we did in 2011 get our high-level summit, and that's worth a look for people working in cancer control from the perspective of what is in there and how one sentence in a political declaration like that can lead to a cascade of work that does start to give you openings to bring the key issues into this global discourse. So whilst that document only had a couple of sentences in it, it did lead to us agreeing to a set of global targets to be achieved by 2025. And I can tell you when we started discussing those targets, WHO and member states were talking about three: blood pressure as an indicator, smoking prevalence, and salt intake, all not so related to disease management. So we fought very hard to extend the set of targets, and we did actually, as a group of advocates, achieve 9 targets at the end. And member states were very open to that. They wanted to do the best they could for non-communicable diseases. So the toe in the door for cancer treatment in general was this one little access to medicines target, which if you look at the documents, you can read in more detail. This led to a global action plan, which in 2013, when it was released, did not have the word radiotherapy in it. That was not through lack of trying on my part or many others' parts, but it did show how there was the lack of understanding, even in WHO, on what cancer treatment is and the importance of the multidisciplinary approach. The good thing about this global action plan is that it does have an appendix. Appendix 3 talks about cost-effective interventions across NCDs, which then become recommendations to member states to prioritise for their work on non-communicable disease. And what we insisted upon as advocates that was a live document. So whilst it was fixed in time at the launch, we have had an update which took place around this time here. And this is also a key document because it includes the importance of early detection and treatment for the high impact cancers where we know a stage shift can make so much difference in both mortality and outcomes for patients. So that appendix 3 is a place where we now do have the words radiotherapy. And whilst it not being very exciting, it is a meaningful change and it has led to so much more. So again, we were able to include a health target in the Sustainable Development Goals. It's quite shocking to think initially people felt health was not needed in the Sustainable Development Goals. So we first got a health target and we now have NCDs embedded in there. And it does have one essential component which I think is so important in cancer control, and this is the idea of access to all, which means that we get this essence of population-based approach, which we need for screening, which is still something that's not very well established. And having worked hard on NCDs over the years, we wanted to focus back on cancer. And so along with this NCD agenda, we did work on what was, we felt, the missing component on disease management particularly, and we were able to secure a cancer resolution in 2017. And again, it's only a few words, but it does mandate certain areas of activity for WHO which were difficult to get done otherwise. And there are things like referral mechanisms, healthcare worker training, just very simple things that were not really addressed in the Global Action Plan very well. So it's a good document to look at to see where are the, where's the mindset of member states and how can you use that to start to bring in the radiotherapy discussion. Next slide, please. And next slide. Oh, sorry, I've got a lot of animation here, which I'll ignore. A parallel to this work, we also looked at what does WHO recommend as far as access to medicines and technologies are concerned. So we were able to initiate a fundamental review of the WHO Model Essential List for medicines for the cancer chapter. This led to a major update, the biggest update they've ever done, and a new approach to doing this, taking a regimens-based approach, looking at both adults and children in the same review. Unfortunately, we could not get radiotherapy included in this list, but it did lead to another set of work. Next slide, please, Sam. Oh, okay. And this was in parallel to the work we did with Mary Gospodarovich as president of UICC at the time, leading a task force to look at expanding global access to radiotherapy under the honorary chairmanship of Tabare Vazquez. And that was the first piece of work that really looked at the investment case for radiotherapy and the enabling environment around that. And so if you're not familiar with that report that was released with Lancet Oncology, I do suggest you go back to that and start to build on that for your advocacy moving forward. Next slide, please. So what happened after that report? Well, we feel we did instigate or at least support the development of the first WHO list for priority medical devices for cancer management. If we've got that access to medicines and technologies target, what is it that is considered priority? And so that document is very useful. It does include some recommendations on radiotherapy machine selection and things like that. So I definitely think this is a document you should keep tabs on and make sure that you flag with UICC or with WHO directly updates that are required over time. That also led to a piece of work in 2018, I think, the first ever WHO model list of essential in vitro diagnostics. So again, that links into the diagnosis. No one talks about diagnosis of cancer, so fundamental. And of course, there's a lot of radiology aspects attached to that, which I think you might want to get involved in. And the other thing that happened, which we don't really talk about, is we actually really encouraged WHO to establish a department for management of non-communicable diseases. And we've got a small but very hard-working team there that's done some great work since the cancer resolution, which you should really get familiar with to see where you can maybe get more involved in that. Next slide, please. Of course, we try and encourage countries to have a cancer plan, make sure we have that full strategy to how to take cancer forward, and that radiotherapy is embedded in that. This is just a few statistics around the progression and number of countries that now do have cancer plans where they didn't before. The US and a couple of other countries have state level plans rather than country plans, but they are there. And we do collect those on this portal, the International Cancer Control Partnership portal. And we do get regular updates actually directly from member states to add their plans in. And this is the first report here from WHO, which was one of the mandates from that resolution. And I think it's also a good reading for you to sort of get a feel for where are member states and policymakers at the global level, and where can we start to introduce maybe more emphasis for improving radiotherapy access and also skills around the world. Next slide, please. And then just two immediate areas where I think we can get more involved. You can click through to the next piece as well, Sam. So following on from the Taskforce report, working with Subi, who's on this call, IAEA, and also our friends at ESTRO in particular, the Giro group was established, the global impact for radiotherapy in oncology, with a sort of 2035 horizon. And I think that group would be a great one to really join forces with to continue the advocacy on the global stage, but also looking at regional and national impact now. And then one key thing that's happening this year, and I hope this coming month, will be the approval of a WHO global strategy towards the elimination of cervical cancer. And I've concluded here a snapshot of the 2030 targets, really trying to lift a comprehensive approach to cervical cancer, looking at vaccination, looking at screening, but also importantly for us, the treatment both of pre-cancer and invasive cancers. And this is one of the first global strategies of WHO that really has embraced treatment. And of course, cervical cancer, such as radiotherapy, is such an important modality for cervical cancer that I think it would be definitely something that you should get more involved in. The resolution was adopted, a consensus text was agreed in February of the Executive Board of WHO, whilst the May World Health Assembly is very much focused on COVID-19, that resolution will be discussed in the next weeks in silent procedure with member states. So we expect this resolution to be adopted by the end of next month. So again, this is a really pertinent new area where member states or governments should be looking to make change. And it's a great way to bring in the conversation about cancer treatment and using cervical cancer as an entry point for that.